Facial nerve palsy is the partial paralysis and/or total paralysis loss of facial nerve, cranial nerve 7 function.
I will be talking about anatomy of facial nerve. Facial nerve arises from second pharyngeal arch and it runs from pons to parotid. Anatomically, the course of facial nerve can be divided into three parts, which are intracranial, intratemporal, and extracranial course. Intracranial course runs from pons to internal acoustic meters, while intratemporal course runs from internal acoustic meters to stylomystid foramen. And finally, the extracranial course exits from the cranium to the termination of its peripheral branches. Facial nerve is a mixed nerve. It consists of motor, parasympathetic, and sensory. In terms of motor, the nerve innervates muscle of facial expression, posterior belly of digastric muscle, stylohyoid muscle, and stapedius muscle. In terms of sensory, the nerve innervates anterior two-thirds of tongue via chorda tympani for taste, while in terms of parasympathetic innervation, it supplies gland of head and neck including submandibular, sublingual, lacrimal gland, nasal palatine, and pharyngeal mucous gland.
The etiology of facial nerve palsy can be categorized according to location such as intracranial, intratemporal, extratemporal, and miscellaneous. The following are the examples.
Next, what are the clinical features for facial nerve palsy? For the lower motor neuron lesion, the entire face, which is ipsilateral to the lesion, is affected due to the unilateral innervation. Meanwhile, for the upper motor neuron lesion, only the lower part of the face, which is contralateral to the lesion, is affected, while the upper part of the face is still spared. This is because of the bilateral innervation. For the forehead features, patient may have loss of wrinkle and unable to raise the eyebrow. For the ocular features, there will be ptosis, epiphora, dry eye, and corneal ulceration. Patient may also have ectropion, lagophthalmos, which is inability to close the eyelid completely, and Bell phenomenon, whereby the eyeball will running upward and upward when the patient attempting to close their eye. Patient may complain drooping of the corner of the mouth and loss of taste. We can also see loss of nasolabial fold, whereby patient unable to puff their cheeks. These are the electrodiagnostic tests for facial nerve palsy.
Management of facial nerve palsy. Management depends on the etiology. Pharmacologically, eye care such as eye drop and eye pads when sleeping, oral glucocorticoids such as prednisolone with antivirals such as acyclovir. Surgically, facial nerve decompression. Complications of facial nerve palsy. Exposure keratitis. Exposure keratitis is a damage to the cornea due to dryness caused by incomplete or inadequate eyelid closure, resulting in loss or insufficiency of the tear film.